Welcome to the deep dive. Today we're getting to grips with something we all encounter regularly in clinic nail fungus, onychomycosis.
Yes, absolutely.
You've brought together some really pertinent UK research, and the goal today is to sort of pull out the most effective ways to manage it. Basically, what's the evidence saying is the gold standard right now.
Exactly. And on onychomycosis, it's incredibly common, isn't it? Here in the UK, estimates suggest, well, a significant chunk of adults have it, and it really climbs up in older populations. And it's definitely not just about how it looks. For a lot of people, it causes pain, makes walking difficult, really impacts their quality of life. Plus, it can hang around and spread.
Okay, so let's talk about why it's often so, frustrating to treat. It's not exactly a quick fix, is it?
No, not at all. The nail itself, that tough keratin plate, it really shields the fungi.
Right.
And treatments take a long time. Then there's the fact that it just keeps coming back for so many patients. It's disheartening.
Yeah, you hear that a lot.
And think about nail growth, especially toenails, maybe a millimeter a month. So even if the treatment works, seeing a completely clear nail takes ages.
So our mission for this deep dive is to really drill down into the recent research, say from the last 10 years or so, 2015 to 2025, maybe pulling in some key older studies too.
Mm-hmm.
And we're focusing specifically on managing it in adults, especially from a UK podiatry standpoint. We've looked through about 50 academic papers for this.
That's right. And I think before we jump into treatments, we really have to stress getting the diagnosis right.
Definitely.
I mean, experienced podiatrists often have a good idea just by looking, but lab confirmation microscopy, culture, maybe PCR, it's really recommended.
Make sure it is actually fungus.
Precisely. Avoids treating the wrong thing, saves patients time, and, unnecessary medication. Empiric treatment happens, but confirmation is better.
Makes total sense. And how severe the infection is really dictates the approach, doesn't it?
Yeah.
We use the Onychomycosis Severity Index, the OSI.
Yes, the OSI. It's a scoring system. Basically looks at how many nails are affected, how much of the nail plate area is involved, and critically, whether the matrix, the nail root area, is infected.
Okay.
So a score of 1 to 5 is considered mild, 6 to 15 is moderate, and if it's 16 or more, that's severe.
And that score helps decide treatment.
It really does. It guides us. For those mild cases, you might get away with just a topical treatment. But once you're into moderate or severe territory, systemic treatment, oral medication is usually needed for a decent chance of success.
Right. Okay. So let's dive into that then. What does the evidence point to as the most effective approach? Is it the oral antifungal therapy?
Well, generally speaking, yes. The consensus is that oral antifungal is the first-line treatment for most adults with onychomycosis.
Especially if it's quite widespread.
Exactly. Multiple nails involved, or if that nail matrix is clearly affected. The reason they work better is drug delivery. It gets into the bloodstream and reaches the nail bed and the nail plate in much higher concentrations than anything you just paint on top.
And when we talk oral antifungals, one name keeps cropping up in the research, particularly the UK-focused stuff: terbinafine.
Terbinafine is definitely the front runner. A big Cochrane review back in 2017 looked at loads of studies and pretty much concluded that terbinafine, usually 250 milligrams daily for 12 weeks for toenails, gives the best results.
Better cure rates.
Yes, higher rates of both mycological cure, so lab tests are clear, and clinical cure, meaning the nail looks normal again. And that's backed up by big trials like the LION study.
Yes, the LION study.
It directly compared terbinafine with itraconazole, and terbinafine came out on top for toenails. And importantly, terbinafine is fungicidal against dermatophytes. It actually kills them.
And dermatophytes are the main culprits, aren't they? Things like trichophyton rubrum.
They are, yes. By far the most common cause we see here in the UK and globally.
But what if it's not a dermatophyte? We do see yeasts like Candida or other molds sometimes. Does terbinafine work for those too?
It's less effective against yeasts and non-dermatophyte molds. That's where itraconazole often comes in.
Okay, so itraconazole is the alternative.
It's a very effective alternative, yeah. Usually given as 200 milligrams daily or sometimes in pulse doses like week on, 3 weeks off. It has a broader spectrum covering those yeasts and molds better.
Right.
But it works differently. Itraconazole is fungistatic. It stops the fungus from growing rather than killing it outright.
I see. And fluconazole, that gets mentioned sometimes, particularly in European guidelines.
Yes. Fluconazole is approved in Europe for onychomycosis, often given weekly, maybe 150 to 300 milligrams, but for a long time, 6 months, maybe even longer.
How does it compare?
Generally, the cure rates reported with fluconazole seem to be a bit lower compared to terbinafine or itraconazole. It's an option, perhaps if the others aren't suitable, but maybe not the first choice based purely on efficacy data, often used off-label in the U.S. too.
Now, you mentioned mycological cure and clinical cure. Can we just clarify what success really looks like? Because a nail looking better isn't always the full picture, is it?
No, absolutely not. Ideally, successful treatment means both. Mycological cure is the confirmation negative microscopy and culture, the fungus is gone. Clinical cure is what the patient sees a completely normal-looking nail growing out.
Right.
But we have to be realistic with patients. Even with the best treatments, not everyone achieves complete clearance. Adherence to the long treatment course is vital, and how fast someone's nails grow plays a part too.
And of course, safety is paramount.
Yeah.
We need to think about the side effects of these oral drugs, particularly for our UK patients who might be on other medications.
Absolutely critical. Generally, they are safe for most healthy adults. Terbinafine has a pretty good safety profile. There's a small risk of liver enzyme elevations, usually temporary, but serious liver injury is rare.
Right.
Itraconazole has more potential issues. It interacts with quite a lot of other drugs because of how it's metabolized by the body through the cytochrome P450 system.
Okay, so more checks needed there.
Yes, careful review of other medications is essential. And it's generally avoided in patients with heart failure. Because of the potential, albeit low risk of liver issues with both, doing baseline liver function tests and maybe monitoring during treatment is often recommended practice.
But overall, the evidence strongly points toward oral terbinafine first.
Yes, for most typical adult toenail cases caused by dermatophytes, oral terbinafine is the primary recommendation, with itraconazole as a strong second-line choice, especially if yeasts or molds are suspected.
Okay, so that covers the oral side, the systemic approach. What about topicals? Treatments you apply directly to the nail, do they still have a place in UK podiatry?
Oh, definitely. Topical antifungals are still a really valuable part of the toolkit.
For what kind of cases?
Mainly for milder infections, say it's just affecting the end of the nail, the distal part, and less than maybe 50% of the nail is involved. Also, they're crucial when oral therapy just isn't an option, maybe contraindications, patient refusal, significant risk of drug interactions.
We've had older ones like Ciclopirox 8% lacquer around for a while. How effective is that, realistically?
Ciclopirox 8% is available here, yes. But as a standalone treatment, its efficacy is, well, modest. If you look at complete cure rates, clear nail, and negative labs, studies often report figures around, say, 7% after maybe 9 to 12 months of applying it every day.
So quite low for a complete cure.
Yes. Mycological cure is a bit higher, but still considerably lower than what you'd expect with oral treatment.
And the newer topicals, are they meant to be better? I know efinaconazole and Devabril are talked about a lot in the U.S.
They are designed for better nail penetration, which is the key challenge. Efinaconazole 10% solution in trials showed complete cure rates maybe around 15 to 18%. Devabril 5% solution was around 7 to 9%.
Better, but still not amazing compared to oral.
Correct. Although many patients do see significant clinical improvement even without achieving that strict definition of complete cure. The UK focus tends to be less on these specific agents compared to the US, partly due to availability and NHS prescribing patterns.
What about Ambrylfine 5% lacquer? That seems much more common here in the UK and Europe, right? You can even buy it over the counter.
Ambrylfine is absolutely a mainstay here. For mild to moderate infections affecting the distal nail, its effectiveness is generally seen as similar to Ciclopirox. Studies show mycological cure rates somewhere between, say, 36% and 54% after 6 to 12 months of weekly application.
Weekly application, okay.
And interestingly, there's some European evidence suggesting Ambrylfine might help prevent recurrence if you use it perhaps weekly after finishing an oral course, like a maintenance therapy.
That's interesting. I've also seen formulations that combine Ciclopirox with urea. What's the thinking behind that?
Urea is a keratolytic. It helps to soften and break down the keratin in the infected, thickened nail.
Ah, so it helps the Ciclopirox get in better.
That's the idea, yes. By thinning the nail slightly and making it more permeable, the antifungal can penetrate more effectively to the nail bed where the fungus lives. Some studies suggest these combination products can yield better results than Ciclopirox alone.
So the big advantage of topicals is safety. Not much gets into the system. But the downside is
the commitment, exactly. Systemic absorption is minimal, so they're very safe, even for patients with other health issues. But you need to apply them diligently, often daily or weekly, for a very long time, typically 9 to 12 months, sometimes longer, until the healthy nail grows out completely. Adherence is absolutely crucial.
And the UK guidelines generally say topical treatment on its own is only really for very limited disease.
That's right. The consensus, like in the British Association of Dermatologists guidelines, is that topical monotherapy is best reserved for really mild cases. Perhaps only 1 or 2 nails, less than 50% involvement, definitely no matrix involvement, and maybe superficial white onychomycosis.
Right.
For anything more significant, you're usually looking at oral therapy or potentially combining topical with oral treatment to hit it from both sides.
That brings us neatly on to combination therapy, using oral and topical together. What's the rationale?
It's really about maximizing the attack on the fungus. You get the systemic effect from the oral drug reaching the nail bed via the blood, and the topical delivering high concentrations directly onto and into the nail plate.
The sort of pincer movement.
Exactly. It's a synergistic approach. The idea is it could clear the fungus faster and improve the overall chance of cure, especially in those tougher, more resistant cases or very thick nails.
Is there good UK evidence for this?
Yes, there is some. For instance, a UK trial looked at combining oral terbinafine with topical amaryl fine lacquer for 6 months in patients with quite severe toenail fungus.
Pardon.
The group getting both treatments had a significantly higher rate of clear or nearly clear nails compared to those just on terbinafine. Other studies have suggested using urea-based topicals alongside oral terbinafine might speed up how quickly the nail looks better.
What about combining 2 oral drugs?
That's been looked at like utraconazole plus terbinafine, and some meta-analyses suggest it might boost cure rates and reduce recurrence. But it's generally not standard practice because the potential for increased side effects and toxicity is a major concern.
So, in a typical UK podiatry clinic, what combination might you use?
A very common approach is the standard 3-month course of oral terbinafine, combined with concurrent use of a topical. That might be weekly amaryl fine, or perhaps daily cyclopyrox, or one of the urea combinations. Often the topical is continued even after the oral course finishes, sometimes for several months to try and prevent relapse.
And the guidelines support this for difficult cases.
Yes, the 2014 BAD guidelines explicitly mention considering combination therapy for cases with a poor prognosis, think very thick dystrophic nails, or significant matrix involvement where you suspect monotherapy might not be enough.
And we absolutely cannot forget the role of debridement by podiatrists.
Oh, completely essential. Regular mechanical debridement, carefully thinning the thickened nail plate, removing that crumbly, infected debris, it's crucial.
Why is it so important?
2 main reasons. 1, it physically removes a large amount of the fungus, reducing the overall fungal load. 2, it dramatically improves the penetration of any topical medication you're applying. Getting through thick keratin is hard work for a topical.
Makes sense.
Studies have clearly shown that debridement plus a topical like cyclopyrox works better than the topical alone. So for anything more than a very mild infection, an all-hands-on-deck approach, systemic drug, topical drug, regular debridement often gives the best odds of success for our patients here.
Okay, let's shift gears now and talk about treatments that maybe aren't recommended or where the evidence just isn't strong enough, particularly based on UK guidelines.
Right. It's important to know what not to do or what's likely to be ineffective so we can guide patients appropriately. Some older treatments have just been superseded.
Like grizafulvin, that was an early oral antifungal, wasn't it?
It was, yes, one of the first. But for toenails, it's really fallen out of favor. The cure rates are just too low compared to terbinafine, often less than 30%, and relapse rates are very high.
So definitely not a go-to anymore.
No. Cochrane analyses confirmed it's inferior to terbinafine, and current UK and international guidelines don't recommend it for adult onychomycosis.
What about oral ketoconazole? That used to be around.
Oral ketoconazole is a definite no-no now for nail fungus. The risk of serious liver toxicity is just too high, and regulatory bodies have restricted its use for this. Plus, the topical ketoconazole creams don't penetrate the nail well enough to be effective.
Okay. And then there are all the things patients try themselves from the chemist or health shop: tea tree oil, Vicks VapoRub, vinegar soaks. What's the verdict on those?
Patients often ask about these, and some might feel they see a slight cosmetic improvement, but the actual scientific evidence for them curing nail fungus is very weak or non-existent.
So they don't really kill the fungus.
They might have very mild antifungal properties in a lab dish, but in controlled clinical trials, they haven't been shown to achieve reliable mycological cure. They certainly shouldn't replace proven medical treatments if someone genuinely wants to clear the infection. It's important we educate patients about their limitations.
Fair enough. Now, the big one, laser therapy. It seems to be everywhere, especially advertised online and maybe more in the U.S. What's the evidence-based view in the UK?
Laser therapy has generated a lot of buzz, you're right. But within the UK healthcare context and based on the current body of high-quality research, the evidence is still considered pretty limited.
How does it supposedly work?
The idea is the laser energy heats the nail and nail bed, damaging or killing the fungal cells.
But does it work in practice?
Well, the results from good quality randomized controlled trials are very mixed. Some show minimal benefit, others show some cosmetic improvement, but not necessarily fungal cure. Systematic reviews, including Cochrane, have consistently highlighted the low quality of much of the evidence and concluded that laser doesn't stack up well against standard antifungals. There was even a German trial showing 0% mycological cure with a common laser type.
0%, wow.
So major UK guidelines, like the BAD ones, do not recommend laser as a first-line treatment. It might very occasionally be considered if a patient absolutely cannot have oral or topical treatments. But even then, the proof of benefit is weak, and patients need to know that, and also about the often significant private cost. It's generally not available on the NHS for this.
Okay. What about photodynamic therapy, PDT?
PDT involves applying a light-sensitizing agent to the nail, then shining a specific light on it. There's some early research, but it's still considered investigational. There just isn't enough solid evidence from large trials yet to recommend it for routine use. UK guidelines say it should remain in research settings for now.
And just to circle back, debridement on its own, not a cure, right?
Absolutely not. It's a vital part of treatment, helping other therapies work better. But just cutting back the nail, no matter how thoroughly, very rarely gets rid of the fungus completely because it lives in the nail bed and deeper nail layers. It has to be combined with an antifungal medication.
Right, understood. So we've reviewed the options. How do we put this all together into a practical pathway for managing patients in the UK? What should our thinking process, our algorithm, look like?
It boils down to a few key steps, really. First, confirm it is fungus, ideally with lab tests. Second, assess how bad it is, use the OSI score. Third, think about the patient, their health, other meds, preferences.
And the British Association of Dermatologists guidelines give us a strong steer, don't they?
They provide an excellent evidence-based framework, yes. Emphasize lab confirmation. Recommend oral terbinafine first for dermatophytes, itraconazole as an alternative, especially for yeasts or molds. Reserve topicals for those mild distal cases or when systemics are out. And importantly, they explicitly say avoid things like debridement alone, PDT, and laser as primary treatments.
And although the U.S. might not have identical national guidelines, is the expert thinking similar over there?
Broadly, yes. The expert consensus in the U.S. is very similar. Oral terbinafine is king, oral terbinazole second line, fluconazole sometimes used off-label, topicals for mild or as add-ons. They also stress confirming the diagnosis and treating any athlete's foot alongside.
So if you were sketching out a typical UK podiatry algorithm.
Okay, pragmatically. Step 1, get that sample for the lab if you can. Step 2, if it's really mild, maybe 1 or 2 nails, just the end-affected, low OSI, maybe start with a good topical like amorolfine or a cycloperoxurea combo, plus regular thorough debridement.
Right.
Step 3, if it's more involved multiple nails, getting towards the cuticle, moderate to high OSI score, then oral therapy is usually the way to go. Terbinafine is the default if it looks like a typical dermatophyte infection. Always after discussing risks and benefits with the patient, of course.
Oh.
Step 4. Maybe consider combination therapy oral plus topical for those moderate cases, or if the nail is very thick, or if the patient really wants to maximize their chances. Step 5. Always address the basics, footwear advice, hygiene. Treat athlete's foot. It's got to be a shared decision with the patient, tailoring it to them. And thankfully, cost for first-line drugs like terbinafine isn't usually the huge barrier here that it can be elsewhere.
And using the OSI score helps objectify that decision.
Definitely. It gives you and the patient a clearer picture of the severity. A score of, say, 18 clearly points towards needing systemic treatment for a realistic chance of cure, much more so than a score of 3. It helps justify the treatment plan and track progress, too.
And briefly, how do GPs typically handle this in the UK?
GPs generally follow the national guidelines, too. Terbinafine is the most common oral prescription for nail fungus from primary care. Topical amorolfine is also frequently prescribed for milder cases. They often refer to podiatry for debridement or more complex cases as well.
You mentioned tailoring to the patient. What specific things should we particularly consider in our UK patients?
Well, diabetes is a big one. Treating nail fungus effectively is more important in diabetic patients to reduce risks like secondary bacterial infection or foot ulcers. So the threshold for using systemic therapy might be lower. assuming no contraindications.
Good point.
For elderly patients, they're often on multiple medications, so we need to be extra careful about drug interactions, especially with itraconazole. Checking liver function might be more pertinent. Terbinafine or even just topical therapy might be safer choices sometimes. And any other significant health conditions obviously need factoring in.
Okay, now we've focused a lot on getting rid of the fungus initially, but the elephant in the room is often recurrence. It comes back so often, doesn't it?
It really does. That's arguably the biggest long-term challenge in managing onychomycosis. Even after a successful course of treatment where the nail looks clear and tests are negative, it can creep back. Could be a true relapse or just a brand new infection.
And the figures are pretty sobering.
They are quite high, yes. Depending on the study and follow-up time, recurrence rates are often quoted anywhere from 10% up to maybe 53% within a few years. A common figure you see is around 20–25% recurring within 1 to 2 years.
Wow.
One longer-term study looking at patients 5 years after successful terbinafine treatment found about a third had relapsed. It just shows how persistent these fungi can be.
Why does it keep coming back? What are the underlying reasons?
Several things are likely involved. Maybe the initial treatment didn't quite kill off every single fungal spore, especially those hiding deep in the nail bed or matrix. Given how slowly nails grow, these survivors can just reemerge later.
Right.
Then there's simple reinfection from the environment spores lurking in old shoes, socks, bathrooms. They can survive for ages. Fungi can also form biofilms in the nail, which are like protective shields, making them harder to kill and more likely to cause a relapse.
And are some people more prone to recurrence?
Yes, certain factors increase the risk. Having a very severe infection to begin with, being older, having poor circulation or diabetes, immunosuppression, and importantly, having untreated Tina pedis athlete's foot that just keeps reseeding the nails.
So even if we get them clear, the battle isn't necessarily over. What about long-term success rates? Do you know how many stay clear?
Well, that 5-year terbinafine study I mentioned, while about a third relapse, it also means roughly 2/3 didn't, or at least about 40% remained completely clear. So long-term success is possible, but recurrence is common enough that we need to plan for it and try to prevent it. You can retreat recurrence, but maintenance is key.
What can we advise patients in the UK to do to reduce that risk?
Proactive prevention is crucial. One strategy is using a topical antifungal as maintenance after the oral course finishes. Like we mentioned, maybe weekly amorolfine for 6 or 12 months. Some studies support this. Definitely treating any athlete's foot thoroughly is vital. Good foot hygiene, keeping feet clean and dry, maybe using antifungal powders or sprays in shoes. Trying to air out footwear, avoid constantly wearing occlusive shoes. Shoe disinfection methods can be discussed too.
Makes sense. Finally, just to wrap up, are there any key differences in how nail fungus is tackled here in the UK versus, say, the US, based on the research and practice patterns?
While the core principles align, there are some definite regional nuances. Availability is a big one. Amorolfine 5% lacquer, as we said, is widely available here, often OTC, making it a common first-line topical. It's not approved in the US or Canada.
Right, so they use different topicals.
Yes. The newer prescription topicals like efinaconazole and tavabarol, available since the mid-2010s, feature much more prominently in U.S. guidelines and discussions, whereas they're less of a focus here, perhaps partly due to cost and NHS pathways favoring established options first. Also, fluconazole has that formal approval for onychomycosis in Europe, but it's off-label use in the U.S.
How does that affect what doctors actually prescribe?
Well, here in the UK, NHS prescribing often defaults to the most cost-effective guideline-backed options first, so terbinafine orally, amorolfine topically. In the US, while terbinafine is still first-line oral, the marketing and availability of newer topicals might lead to them being used more readily, perhaps especially if patients face high copays for oral drugs. The OTC availability of amorolfine here also means many patients self-treat mild cases first.
And the laser situation.
Huge difference there. Laser is marketed very heavily and used quite widely privately in the US. In the UK, it barely registers within the NHS context due to the evidence gaps and cost-effectiveness questions we discussed. That's a major divergence.
Any difference in when people seek treatment?
Possibly subtle ones.
Yeah.
Maybe in the UK, treatment for very mild, purely cosmetic cases might be initiated less readily within the NHS compared to the US, where cosmetic dermatology is a bigger market. But for symptomatic or risky infections, the approach is generally similar. You might also see slightly more emphasis on things like shoe disinfection in some European guidelines.
So the core science is the same, but availability, cost, and healthcare systems create variations in practice.
Exactly. The fundamental standard of care diagnosed properly. Use terbinafine first for most. Consider topicals. Debride is pretty consistent. But the specific choices around topicals, fluconazole status, and definitely laser use show clear regional differences.
This has been a really thorough deep dive, incredibly useful. So pulling it all together for podiatrists listening in the UK who want to ensure they're providing that gold standard care, what are the absolute key messages?
Okay, the main takeaways. Prioritize oral antifungals, particularly terbinafine, for most adult patients, especially moderate to severe cases or where the matrix is involved. Recognize the role of effective topical agents, like amorolfine or potentially combination products, for genuinely mild infections or as valuable adjuncts. And crucially, don't underestimate the power of combining therapies oral plus topical plus regular thorough debridement for tackling difficult cases.
It gets beyond just picking the right drug, doesn't it?
Absolutely. Accurate diagnosis, ideally lab confirmed, is step one. Assessing severity properly, using tools like the OSI, helps guide treatment intensity. And tailoring that treatment plan to the individual, their health, lifestyle preferences, is vital. And because recurrence is such a big issue, educating patients about the chronic nature of this, the importance of adherence, long-term management, and those preventative strategies is just as critical as the initial prescription.
And acknowledging those UK versus US differences helps contextualize things too.
Yes. Being aware of why we might favor amorolfine here, or why laser isn't standard NHS practice, helps in discussions with patients who might see different things online.
Perfect. And finally, just a thought to leave our listeners with. Given how stubborn recurrence is, what might the future hold? Beyond our current drugs and debridement, what kind of innovative strategies could emerge for long-term control or prevention? Maybe better ways to get drugs through the nail, or targeting the fungus differently, or even looking at the patient's own immunity or biomechanics. Something to ponder. Thanks so much for joining us for this deep dive.